Steve, you mentioned a little bit about currently you have a person that makes sure that everything, whether you're buying paper towels, BCG, whatever, that is constantly looking at through group purchasing organizations. So do you think there's an opportunity, given our network of large groups across the country, do you think there's an opportunity for urology groups to be involved, more involved, even with potentially the institution or the formation of our own GPO?
Absolutely, because of the specialization of the products we use out there. I think we've got strength in our numbers and buying that. And in many of these relationships with the GPOs, to get the better pricing, you've got to show your practice's current volume. And they're pricing it based on your volume. So if we come together as a group, I think that gets people's attention and you can continue to lower the cost. So I'm a big believer of that, especially watching it in the hospital world for 30 years and coming across into the practices. Also, you can become part of several group purchasing organizations and you can bid amongst them and see where you get the best deal. I paid $250 to join a local cooperative there in Oklahoma and was able to save $40,000 on a CAT scanner. So you have to be creative and continually look at these different relationships and to achieve the bottom line for the physicians.
And correct me if I'm wrong, but I think your point is well taken, is that your discounts and everything, it's really all about volume. And to me, I think knowing just a little bit to be dangerous is that the GPO has the ability to help establish some guidelines or make recommendations in terms of what potentially could be best practice managements or at least algorithms to help drive volume. Is that correct?
Yes, I think obviously they're trying to turn the product, and many times they're the middleman for the manufacturers, so they're getting a base point for pushing the product through the system. And I think you just have to ask tough questions. You have to monitor it every day, because you may have negotiated a price and then in 2 months they start raising prices, and if you're not watching those invoices, it can come back to haunt you. And so that's what we've found. And so I've told all of our GPOs, we're going to make a change based on price if there's no difference to the doctor. And we're moving towards more standardization in our clinic as far as systems and processes, and then kind of following a doctor preference card. But we were kind of practicing as 20 different doctors, and we're moving now more towards standardization.
Bryan, and Dan, what are you putting in best practice standards, utilizing AUA guidelines? We talked a little bit about NCCN guidelines. What about AUA guidelines? How are you all incorporating that into your daily practices for, obviously, prostate cancer, but hematuria, BPH, those types of things?
We've been trying to institute and remind people about the AUA guidelines. It's actually the assignment of one of my partners to be the guideline police and try and keep us all educated. And then I have found that some of that now is becoming more and more important when you negotiate your private payer contracts, to say, we are following best practices and trying to show them I'm saving you money by efficient evaluation of certain problems, and that's just recently become more of an issue.
In San Antonio, we are currently trying to evolve to centers of excellence, whether that be for low testosterone, hypogonadal men, whether that be for refractory overactive bladder, whether that be for infertility, so we can centralize the management of those patients' care under one heading, which will allow us to be more efficient in how we manage those patients, prevent duplication of services. There's 25 docs in San Antonio, and for a while there we were practicing as 25 individuals, and we definitely need to evolve to more standardization. It's going to help us contract in the future, as Bryan said. One
way we're doing is we're beginning to write algorithms for conditions, and we're doing it with discrete data using the AUA guidelines. And we're going to run that against our EHR monthly to get back how well our doctors are doing with the guidelines we've agreed on. And so we've done low testosterone, female incontinence. We're now working on BPH and stones. And we're writing a formula of discrete data, and we're setting ranges between green, yellow, and red. And we're going to be measuring, especially like female incontinence, there's a surgical intervention, and then how does it change the risk of the patient? So we're creating state of health scores working with a software company. And so far, if these first 4 work and the smell test there, we're going to continue to do all the major disease categories. But the good news is we give feedback to the physicians because we review it monthly, and we also want to go to the managed care companies and show them we're practicing the best standard, and then we want part of the premium if we lower the urology side of their premium dollar.
Yeah, you got to have data on that.
And as we evolve to an ACO model, which is going to be carve-outs, we want to be able to share in that profit. The big hurdle in all this is, can you change physician behaviors with red, green, yellow, and performance?
Well, and I think that's always the challenge, is that, you know, especially surgeons in particular, and Steve, you probably have a better handle of it coming from the hospital side, is that, you know, my favorite line is you ask a particular surgeon who's the best 3 in the area, he doesn't have any problems naming himself, it's the other 2 guys. So, you know, I think, you know, physician behavior really is a challenge. So my question is, so you're using the guidelines, you're using your EHR, and you say, okay, Dr. X, we've pulled some random charts, here's the guideline, here's where you stand. Now, how much time do you wait do you report him out in relation to the group, or do you report him out to how he did just to the guideline?
I think this is evolving. I mean, we're going to start with, are we all consistent, right? Do we have an outlier in our group? Do we have somebody that's practicing differently than the AUA guidelines? And then I'll let the partners deal with the partners. But I don't think this is the thing where you bring in a sledgehammer from day one. In my 30 years of experience, physicians react to data and measurements over time, not a snapshot. And so this is so new that I think we're going to have to work through it. But the other thing is, we're showing if there's improvements happening. Do you move through, if people failed on the female incontinence, how quickly do you move to surgery? And is there a measurement out there in their state of health score on how well the patients are doing as you go through different drugs trying before you actually get to an intervention? So I think there's different ways of measuring this, but part of it will be the cost side of the equation. And you're measuring the outcome side of the patient, because you're measuring their discrete data against your interventions.
No, I think there's no question that, as for those of us that we believe in this model, that large integrated groups with the ability to create centers of excellence, to have a few physicians concentrate on incontinence, advanced prostate cancer, infertility, pelvic vault reconstruction, that hopefully that the data, which to me I think is the new currency, needs to be shown. And because you can show that you practice better medicine based upon some predefined metrics that I think are constantly being evolved and people are looking at, that at least for right now, your reimbursement should be higher if you can functionally prove that. And I think that is the challenge. So